Good morning. It is April 19th, 2022, and this is our second Benefits Committee meeting for 2022. Thank you all for attending. Sean Fleming is here today, and he will be going over our claims experience, our NAVMD reporting. He's going to discuss our 2023 timeline, and then we'll have some time for questions. So I will turn it over to Sean.
Morning, everybody.
Morning.
I always remember this line from a movie. I can't remember the movie, but there was a priest and it's a big church and there's like 4 people out there and he says, "Welcome ye few but faithful." So you guys are few but faithful today. I don't know why that line always stuck in my head. I just wish I could know what movie it was. So what we wanted to do today, thank you all for coming, is give a little update. As you guys know, when we met last, claims, as we're seeing sort of globally, claims are on the rise, and they've continued to stay at some little bit higher levels. So one thing we want to do with the committee is make sure you guys are informed. Obviously, as claims are higher, there's potential for cost increases. There's also option to look at benefit changes and some of those things. But what we wanted to do more than anything was just get back together with you guys so you're informed and give you an idea. What I thought I'd do is actually might go in reverse because we'll spend a little bit more time on the claims. If you want to go to the back, there's actually a timeline. I wanted to we'll hit on that first as far as you may remember when we met last, we talked about the city had not done an RFP in a while for the carrier, for the medical plan. So we are doing an RFP this year. And I wanted to talk about, just make sure the committee really understands kind of timeline on that, but also what that entails versus what it doesn't in some regards. Because some of you remember, you've been around this committee for a long time when we were fully insured. There were times we were bidding almost every year, and every carrier had a network change and a schedule of benefits change, and pharmacy was different and all those things. So I wanted to start with the RFP and then we'll dive into claims because that's kind of the bulk of the discussion. So real high level, the RFP goes out this Friday is the targeted date. So what's in that RFP? The big thing in that RFP obviously is the medical. But what I wanted to talk about with the committee is just make sure everybody understands what that means in a self-funded environment, because it's a little different than fully insured. So obviously with fully insured, we're always out looking, trying to see who would give us the lowest rate with the best schedule of benefits. And you guys may remember that. With self-funded, what we're really looking at, and we'll see with the claims, you guys know that a very small portion of what you pay for the overall program goes to that third party, Cigna in this case, to administer the plan for you. And then there's reinsurance, which you happen to buy through Cigna, but you don't have to buy that through Cigna. You can buy it from any reinsurance company. It's just Cigna's been competitive, and there's some advantages in that they automatically do all the accounting. So if you have a big claim come in, you don't have to send all the data to a third party and wait for a reimbursement check. Cigna just does it automatically. But that's really the bulk of your costs to that third party under a self-funded medical plan. The bulk of the spend is your claims, right? So with the claims, what are we looking at? Because that's really the most important part of the RFP. What we're going to be looking at is a couple of things. We're going to be looking at the network of providers, right? So who's in the network? We're going to compare everything compared to what you currently have, and then there'll be a very detailed analysis on that. We're going to compare all the pharmaceuticals on their drug list to say, hey, they say they're cheaper, but do they only cover 80% of the drugs that are current formulary coverage? Yeah, that's why they're cheaper, because they don't cover those things. So we're going to go through that process in that. But the biggest thing we're really looking at is what is the discount they're achieving at the facilities where your employees are going, right? So, discount for, just to refresh, what does that mean? Let's say I go have an outpatient test that the retail rate they would charge you off the street is $1,000. On average, insurance carriers are getting about a 60 to 65% discount. So that means that the plan, after whatever your copay is, plan pays about $350 to $400 for that service. And then that's what your cost share is based on. So what we're looking at more than anything is that network and the network discounts. What the funding ultimately needs to be to cover the plan is really if everybody had the same network discount, let's say. If everybody has the same network discount, the funding shouldn't change from carrier A, B, C to D because your claims are expected to cost the same amount. So I just wanted to do a little kind of education on that to let you know the RFP is out, but those are the bigger things that kind of change with self-funded and what we're looking for, because that's 90% of your cost of the claims. So we want to make sure that even if somebody charges you $3 less an employee per month on administration, that doesn't mean you're going to pay 15% more on your claims, which is a much bigger number than the administration. So I just wanted to cover that a little bit. So that RFP will be out. There'll be a selection committee. We'll go through that process. Obviously, also the services being offered by the carrier, any add-ons, wellness, any of those things are all part of that. And I'm not dismissing any of that, but the big thing is really tied to the bulk care cost, which is so that RFP will be out for about a month. And then we'll have a couple of weeks where we evaluate that and work with that selection committee to make a consideration on that regard. While that's going sort of concurrently, we're going to be working with the HR team and finance team on actual budgeting projections, based on updated plans. So do you guys have any questions on the RFP? That'd be easier to start there, and then we'll dive into the claims. So I know that sometimes when people hear there's an RFP out, they freak out and instantly think, oh, it's going to mean we're going to change carriers or so. I just like to give you guys, if any of your team members ask you, like, hey, what does this mean for us? So you can at least kind of explain what the city's looking at. All right. Everybody ready to go back to the numbers?
Yes.
And I know we said it last time, I'll just for everybody, so there's no question after clarification. The clinic is not part of that RFP. There probably will, or the plan is probably next year, because the clinic hadn't been bid in a while. It's like, we'll look at that. We felt it was better to make sure the medical was decided first, because there's integrations that we may want to know about. So that was why the order was done that way. But just so everybody knows, just because I know a lot of people know the clinic is Cigna, I don't want anyone to freak out and think if the medical changed the clinic, it is tied to it in that regard. All right, so on the first page, as you open up after the agenda, we have the first 3 months of claims experience for the current year. And believe when we were together last, we may have had, I think we had January claims. So we have February and March claims that are updated. If you want to go just to that, the first column is total plan funding. Based on enrollment, we have about 1.6 million going in. And then I know Jay's off today, but quarterly, I think Jay's checking this against all of their stuff just to make sure numbers bounce up. Of that, just looking at March, of that 1.6 million, this is what I was talking about with the RFP. So 1.66 million, only $68,000 goes to Cigna to administer the plan. And then 115,000 for that reinsurance, for that stop loss protection. Then we have our medical and pharmacy claims. Medical claims, we had a good month in February. Compared to the other two, claims were up in March at 1.5 million. So we had a higher month. Pharmacy was actually down a little bit at 378,000 pharmacy claims. So 2 of the 3 months we've had deficit. We had 225,000 of deficit in January and 441,000 of deficit in March. And pretty much a break even in February. If you go down that column, you will see we just received the pharmacy rebates, which is an offset to that, which was just shy of 1.3 million, so 1.277. Last year, just to give you an idea, that was $1,075,000. So the pharmacy rebates, when we estimated in the projection, we just used last year's pharmacy rebates, so we don't assume an increase kind of year over year. So that does pick up a little bit of money to help offset some of the higher claims. We're going to dive into some of the areas of utilization in a minute, but
Question on the pharmacy rebates. Do we get that at the same time every year?
yeah, pretty much.
Beginning of the year usually?
Generally around second to third week of March. So that just came in. So that offsets obviously the deficit right now and leaves the plan positive by 635,000. But obviously that one-time boost to the pharmacy rebates is offsetting that right now. So if you take a look, kind of if you go down, you'll see two little horizontal bar graphs there. We've got medical and pharmacy claims broken out, so you can see the increase in those cost categories. At 2.7% year over year increase in medical right now, and a 4.9% increase in pharmacy. Now, if you looked at this page on your own, you would say, well, I'm confused. If we're barely up, you know, what's going on? But if you want to look at the mirror image of that for last year, on the bottom, you see that last year you were up 20% on medical and 9% on pharmacy. So although you're not up by alarming numbers year over year, that compounded 2-year kind of increase is reflective of those plan costs running that much higher. So we'll talk about some of the city specific numbers just to give you a little bit of an idea. You know, globally, your guys' trend here is pretty consistent with what we're seeing in the market. I know that's not good news and doesn't really make anybody feel better. There's a couple of prevailing thoughts. I talked about it a little bit at the last meeting, but we've seen a couple of things. One is we had towards the end of last year and the beginning of this year, we had a number of increased costs, predominantly due to Delta variant. We had a lot of hospitalizations, a lot of more complex things related to that. We had a lot of increased costs actually due to testing. So one of the problems with testing, when the government came out and said it has to be covered, basically it hamstrung the insurance carriers from being able to put any real cost restrictions on. So there's all these places that were charging $400 or $500 for a COVID test on the back end, and the plan had to pay it. So it's pretty egregious. Now I think overall, when we look at some of the testing numbers, I think more and more people are just testing at home because the home tests have become so readily available. As you know, the insurance plan is required to cover those now. You guys may have seen that. There's, you know, you can get those through the insurance plan, but obviously, you know, I think most of those tests average about $10 to $12 a test. So there's big savings there if people use those. You don't have to go get in line somewhere and do all those things. But the biggest kind of area that the underwriters and actuaries feel is driving costs is the backlog from COVID. So all the stuff that didn't get done during second half of 2020 and first half of 2021. Now people are filtering back to the doctors. You know, they're anecdotally, I mean, we've heard so many stories of people. I had someone in my family that they were due for their mammogram during the height of the pandemic. And, you know, they just didn't end up going that year. You know, so they went a year later. You know, for my family member, luckily everything was fine, but we've heard a lot of stories of, hey, I didn't have my colonoscopy that year. I put it off, I did this, and they're finding higher prevalence rates and cancers. And when you find them later, the cost sometimes triples, like a stage 3 versus stage 1. It's not just, oh, it went up, a little bit, because it actually can quadruple. And that's setting aside just, the side of survivability and some of those things in that. When you talk to people a lot smarter than me about what they think is going to happen, they believe second half of this year, we will start to see more of a return to normal utilization patterns. But we just don't know 100%. But I would say about 80% of our clients, their claims experience looks very similar to this right now. So it is a little bit of an industry trend, but unfortunately that doesn't really soften the blow. The other thing, obviously, that is impactful, there's some protections with contracts with hospitals and doctors, but what was the last inflation number? 8.5%. You guys remember that when inflation was 2%, medical was always 8%. So think about if regular inflation is 8%, the impact that starts to have on the healthcare system. There's also a lot of shortages of staffing, so those are kind of all things putting pressure on the system right now.
Question on the COVID, did the plan get reimbursed by the government at all?
Like in the very first year, there was funding
We didn't
and
get anything last year.
reimbursements, but no, nothing in last year that I'm aware of.
Not even for testing, nothing like that.
No, I think the first year, I think Jay was able to submit some stuff to the county. And I'm so bad with all the acronyms, but I think there were ultimately, was it 2 or 3 different acts that came out, and there were some. We've had a couple clients that had potentially used some of those funds for that. When I would ask most clients about it, they'd spent it already on other things.
Yeah, so, we did get ARPA funds,
Right.
but that has not been allocated to reimburse the plan. They're still going through, there's a lot of project list requests for the ARPA funds that we did get, so that's COVID related money, but it is not anticipated that it's going to be used to yeah, and I don't even know if that's an allowed use for the ARPA funds, so.
Yeah, we haven't been talking about that at all.
Yeah.
It's been more like projects in the
Yeah.
community kind of thing.
Yeah,
That's where they're wanting to put it.
there was one, but it wasn't ARPA. Again, I can't remember all the acronyms. I know one school district, submitted to the state to use some of it to like offset an increase. But I can't remember if that was like a specific one for schools, or how they could allow it. So that we've seen some different things, but for the most part, that first year when there were a bunch of testing costs, a number of entities submitted. Most of them though was $40,000-$50,000. The hard thing with some of like the bigger claims is, and I think this is partially driving claims in some regards. So I'll say it delicately, but there were some incentives to hospitals to code things as COVID.
Right.
Where they got different funding and reimbursements, and they got higher reimbursement rates, and they were able to charge more. And I think that, not to be political, but if you watch the news over the last year where they talk about, what was the actual prevalence of COVID, because somebody goes in for a knee surgery, they contract COVID in the hospital, and now they're calling that whole thing a COVID claim. That's kind of the other problem with trying to submit for reimbursement, is like now you got to dig in and go, well, that was actually a knee surgery that the person just happened to get COVID, but maybe the COVID didn't even impact them, but then they were coding it as COVID in that regard. So that's one of the other challenges with trying to submit for the if you guys want to take a look on the next page, if you want to flip down, this is just large claims for the year. Anyone that is over 100,000. What's different, I would say, so far on this list than past years is 4 of the 5 individuals are employees. In the past, we've had a lot more top claims that were either dependents or spouses. So this just gives you an idea of some of the claims that are going on there. From the claims experience point of view, obviously your stop loss restarts on January 1st. So everybody starts over as those catastrophic, those higher cost claims, as they increase over time, that reinsurance starts to kick in. So that has your claims typically front loaded a little bit in the first half of the year because everybody started at 0. And then the next page is just a graph of that claims per employee per month. So we take the claims each month divided by the number of employees on the plan. Just to give you a moving average there. So Cameron put together some, on the next page, just some utilization data from our benchmarking and data analytics system, which takes a look at some of the different utilization numbers. And on that page, which is labeled page 1 of the data analytics, so the per 1,000, that's per 1,000 members, that's a number. That's kind of the number on top of that is your actual number of visits. The per 1,000 is kind of the moving average, if that makes sense. Where the number on top, you see 1,699 office visits versus almost 11,000 a year before. That's because there's only a couple months of data in there. So that one that's highlighted is more accurate. Overall, you see office visits are up. Just so everybody knows, because the clinic submits data, even though it's 0 cost, submits an office visit, those clinic visits are also captured in this as well. But what you guys see is you see office visits trending up. And that to me is really indicative of the fact that the years before, things were a little bit down with the pandemic. But obviously, as you know, people are catching up, as people are finding conditions, they're having more visits. So we see an upward trend in office visits. What is a good number, and I think this is partially because you're throwing those clinic visits in there at 0, is the average that the plan is paying for an office visit is only $45. It was $53 last year. So that's tremendous there. You know, the plan, everything is good there. The next line down, your preventative visits, you can look at per 1,000. Gives you an idea. We're a little bit low on preventative visits compared to the moving average right now, but nothing overly alarming in that regard. And then we've got pharmacies down there, pharmacy scripts per member. That number is going to be a little skewed because think about a lot of people will get prescriptions in 90-day supply. So, and you know, in this system, we don't have all that data yet. So it's going to be skewed at the beginning, but that one will wash out more towards the end.
Question on the pharmacy.
Yep.
Just like you said, on the office visits, the clinic counts. When we get medications from the clinic, does that count towards us also?
It does. Yep. Just be at 0 cost because they're submitting it. Okay. Yeah. Down below on the next page, what we're able to do in our data analytics system is take everybody else in the system. So it's not necessarily all public sector. When Cigna does their annual report for us, it will be all only public sector. But that dash line is kind of the benchmark. What is everybody averaging in that system as far as a paid dollar amount per office visit? So you'll see that the city is quite a bit lower. So some of that's a savings from the clinic driving that difference there. And then on page 3, we have that scripts per 1,000. So again, it's not mature this year. You could kind of stop that line at January where you see The city's still running lower than the benchmark with all those scripts going through.
Question about, I know we're going back a little bit.
Yeah.
Office visits, does telehealth count towards that also, or where does that fall into play?
Kind of depends. So now what you've seen is, my doctor did this during the pandemic, is the easiest way to say it. It's like, I was doing a telehealth with them. That definitely will go through as an office visit, if you do that with them. The MD Live or Amwell or those, I have to double check how it gets coded into the system. I believe it's gonna be outside of this, because this is gonna be more of a regular office coded visit.
Can you tell if people are using that, it's getting increased?
Yep, we can get a separate report just on those kind of third-party telehealth. We'll request that. So if you want to real quick, flip to page 5. This is the one that's kind of interesting to me, and I'll go backwards to the actual numbers, but you guys remember on the last couple, we looked at the city was below the benchmark, right? The dashed line. Those are dashes, not dots, right? The dashed line was on top, remember, and the city was below it, which is a positive. If you look at, this is paid amount on, actually, yeah, this is paid. Let's go back. So ER visits, if you want to go to page 4. ER visits, the city's kind of trending up a little bit. We've seen a lot of ER visits in that regard. So I look around and I see the pop-up like on Gulf to Bay, the standalone ER. I know there's a couple up north as you go up, depending on how many employees live up there. I think, reminding people and constantly having that message out that the ER we want ER to be for emergencies, is really important in that regard. Now, it can fluctuate year to year. I mean, all it takes is a couple people having, use this as an example. If I'm having, if I have even something where I need minor stitches or something, if it happens at noon, I can go to an urgent care, I can go to the clinic, maybe I can go to all those places. If it happens at midnight, I got a lot less choices. Most of the urgent cares, I think, close at 9 or 10 o'clock. They're not 24 hours. So all of a sudden, like, my options are reduced. So a couple things like that can fluctuate, as you see, but throughout the year, overall, we see the ER utilization trending a little bit higher than we would like. So it's just always important to kind of keep that out and remember in that regard. And the ER visits, you see quite a high cost in that visit. So just want to keep that out there for everybody to remember that the ER is a very expensive place to go. We also see problems where, somebody knows they need a couple of tests to maybe get to a next step. And if you go to the ER, they're going to do them all right there. Right? I heard someone told me a story the other day, they were having issues and basically they went to the ER, she had, an pelvic ultrasound, she had a CAT scan, she had an X-ray and an MRI. So then the person needed a procedure, so gave all that to their doctor and the procedure was able to be scheduled. Well, those tests in the ER cost 5 times going standalone and having that done. So that's kind of one of the challenges there. And not to say that you might not have even needed all those to still get to the same results. So that's one of the problems we see. On page 6, hospital admissions, just looking at occurrences per 1,000, slightly higher than the benchmark, but nothing that really alarms me there. But what it does tell us is we've got people, we've got people going to the hospital, so they're having more serious, medical incidents that they're being admitted to the hospital. And then on page 7, seems like we're having more babies this year. So our delivery occurrences are up a little bit. That's kind of highlighted there. What's that?
You don't say.
So deliveries are up, and also down below, we've got a lot more ambulatory surgeries per 1,000 in that benchmark. So there's an upward trend there in that regard. Is that backlog from people not getting stuff done during COVID? Most likely industry-wide, based on what we've seen, that's probably the case, but there's no way for us like individually to look at somebody's claims and say, oh, that they put that off and should have had it done a year ago. But that's the prevailing thought as to what's driving that. So hopefully we start to see some normalization over next year. So that's kind of it. We just wanted to give you guys a couple of the areas that we see some things a little bit higher than normal. Is there any questions on any of that? So that was the bulk of the agenda for today. We talked about the timeline. Anybody have any other general questions? Yes, sir.
Last time I spoke with you, I had mentioned the concern about the dental options you had as far as some things you could go to, PPO, HMO type deal. Is there any truth to the rumor that that's not only spreading from the dental, it's spreading down the internal and family practices also?
In the sense, are you talking
of the options you would have?
You're talking more specifically, just to recall the conversation, you're talking more specifically on the DHMO?
Yes.
Yeah. So generally speaking, what we see on DHMO is most DHMOs now have largely become limited to what I'll call like the chain providers. So most private practice dentists are not taking the DHMOs anymore. So just for anybody that's not familiar, the DHMO is really a fee schedule based. There's a set cost, almost like an old HMO plan for every service. There's no annual cap. So some people are drawn to that because one, the cost is typically lower for the premium, but then they kind of know what their costs are going to be. The downside of those have typically been, it's normally your private, family practice, and that's what you want to call it. They typically don't take it because they don't want to be tied to that fee schedule. So that's part A of it. The DHMOs, absolutely. If you look at most of the networks anymore, it's pretty much only like I don't know if this is the actual name, but like Bright Smiles and, a retail type location where you may not even know the dentist you're getting. The family practices right now, most of the established dentists.
But not so much in dentistry, family medicine, general medicine. Is it trickling down into that part of the field?
So not really. I would say for the majority, I'll clarify that in a second. But for the majority of private practice doctors, they can't afford not to take insurance. They have to do that. What you will see is they like a traditional HMO plan, which the city hasn't had for a while. Not that many people have them anymore. The traditional HMO plans, a lot of the doctors don't necessarily want to participate in that because it reduces the amount that they're reimbursed. But we haven't seen like that many providers drop out of kind of the traditional HMOs. What I will tell you, I have seen more of in pockets is, and I'll say my doctor did it, but So my doctor's model, when I had to switch doctors, is he has 4 nurse practitioners that work for him. And then he handled some of his more long-term patients and the more complex cases. But for your annual checkup, all that, you see the nurse practitioner, right? And he's more there as the overall kind of consulting. He went, and I've seen this, he went to, you have to pay, it's an absurd number. It's like $2,500 just to be able to see him as a VIP type thing. So my wife and I looked at him and we're like, wait, so that would be $5,000? And they called me and they were trying to sell me on this. And they're like, well, don't you want to do this and this? And I actually stopped him on the phone. I said, just so you know, I've never actually met the doctor. Like I've always seen the nurse practitioner. So I'm not gonna pay $5,000 to see someone I've never met. But what's interesting is when they do that, they're still billing the insurance when you see them. So that's just like an access fee. We have seen some providers go that route where they're going more, like there's one called MDVIP and there's a couple of them. We've seen some of the general practitioners go that route because it's the only way they can staff the practice because, they're getting $40, $50 a visit. They gotta have nurse, front office staff, all those things. So seeing a little bit of that, whether or not that changes, as interest rates go up, depending on what happens with the economy, and, we could see some changes there.
There's a little truth to the rumor.
Yeah, there's probably some cases of it happening, but I wouldn't say it's global or widespread in medical like it is in dental.
Sean, do you know how we're doing on Motivate Me?
Okay, just saw this. Last one. Let me see I don't think I have the breakout by department
Okay.
so far. Let me see.
Got a redemption report yesterday.
Yeah, there was a redemption report. Did they have a count on it?
It had an account for March, just for March. But we can get an overall year-to-date one if you like.
Yeah, it's just helpful to remind, people how they can participate in terms of these rates. I mean, we're having a rough year. We had a really bad year last year, right? We had 1 month that was positive. So those are just things that the employees can do to help and also take care of themselves and be financially rewarded for doing so. So just trying to really push that program as much as possible.
Yeah, you had about $2,800 in redemptions in March, which is pretty good for this earlier in the year, I think. But we'll see if we can get a report and also benchmark it to last year.
Yeah, and just
At this time.
also maybe for the next one, if we could have an update on Armada and how that's going and participation, which is our diabetes and heart disease prevention program and maintenance program as well. That's the one that's free to the employees to use, and they only get paid if we're successful. So I'm just curious. We launched it in January, so it's only been a couple of months, but it would just be the people who signed up, they still participating, like that kind of stuff.
Yeah, we'll definitely get that. And just so you guys know, you started off with the best participation I've ever seen from an Armada rollout. I think, and you guys remember some of the numbers, but like the first 2 or 3 reports we got on it, everybody that was eligible basically signed up.
Mm-hmm.
So to Jennifer's point, now the question will be, are they continuing with that program? But just to have that many people who are eligible, normally we have people that they're eligible, but they're not interested in the program. They're not into it. So it would definitely be good to see once we get through another month, probably, that will give us, kind of where some of the benchmarks they've hit. So, and definitely if you guys aren't familiar with that program, or if we need to get any more buzz out of that, I think it's a really worthwhile program for people to
Well, we're lucky too, because the clinic staff also is informing all of our employees if they would be a good candidate when they actually have office visits. So that's a plus for information.
The incentive programs that you are going to offer, how are they doing?
That's what I just asked him about. That's what Motivate Me
You
and
Motivate Me
Armada
is
is.
incentive
Yeah, both of
programs,
those are the
okay.
incentive
That
programs.
is incentive program.
Yeah, so we should
Yeah,
have,
you're gonna-
you know, like
you're
a,
gonna change.
in total, how we did,
But next thing I wanna know
yeah,
is that number, because,
for last year. I know we had an increase over last year. We obviously want to continue to have those increases, so.
so the numbers, the overall office visits, which are included, the clinic is included in, you would say they are working, and that will help this, that's what helped this number come up.
But overall, utilization is definitely up, so that's, generally reflective of more issues going on. Hopefully we start to see that stabilize or come down a little bit in the next couple of months. And we have, we've seen a lot of groups, not everybody obviously kind of has this effect at the same time. But we have seen some groups that had increased that are now, we're starting to see a little bit of positive trends. So I think the city, maybe because of size and just the number of people, it may take, a little bit longer for that to catch up, but hopefully we start to see a little bit of a change in course there.
Any other questions? No. All right, well, thank you guys for coming out. Please continue to spread the word. Also, both from a prepare for increase, right? Because that's gonna happen. And also to, yeah, I don't want it to be a surprise. It's gonna happen. And then also in terms of all the programs that we have available to try and help mitigate some of this stuff.
And we also have our new wellness, well-being coordinator that started, Leo Garrison. And he'll be reaching out to department heads, and so he can get out in front of the departments during your meetings. So he will want to participate with you guys in the future.
All right, thank you, everybody. Good to see you.
Thank you.
Have a good one.
Yeah.